All right, let's get started here. I'm sure more people will join. Welcome everyone to tonight's webinar, Men's Mental Health. So fatigue, low mood, and the connection with low testosterone. Tonight, we have the privilege of speaking with Dr. Erik Nelson from from Neurvana Naturopath Clinic here in Calgary. So thank you for joining us tonight.
Thanks for having me.
Yeah, great. Let's get started. So why don't we start with maybe kind of breaking down what testosterone is and kind of some of those functions in the body when it comes to men.
Yeah, perfect place to start. So testosterone is what most people classify as the stereotypical male androgen hormone. It's very important for both men and women. Of course, men just have quite a bit more of it, and it seems to dominate the hormone picture for the men in your life. So testosterone has a number of different functions from the brain all the way down throughout the body, which is why it's so important. It can touch many different systems. It has a role in producing red blood cells. It can make you fatigued if you're not having enough of those. It plays a role in recovery from exercise, the response to exercise. So if you're putting in all the hard work and you're not seeing the benefits from your exercise, from basically in terms of growth of muscle mass and recovery from your exercise, that could be related. But it also has receptors all over the body. So if you imagine testosterone is it's just one of those major hormones which float around the bloodstream and have effects at distant locations. So it can have effect at the level of the hair, which is a really common complaint that comes into my office which is male pattern baldness or hair loss, which people are assuming is related to testosterone. And the reason that it's important is because testosterone is one of those growth factors, which is important for actually stimulating the growth phase in a hair follicle itself. So literally from head to toe, there are receptors for testosterone, and each receptor, depending on the site of the body, will have a slightly different downstream effect. But testosterone, even in really, really small amounts, can have really outsized effect at the level of the tissue, which is why even small fluctuations, even a 10% drop or a 15% drop can start to show symptoms in a patient.
Yeah. And what would be kind of more of those symptoms? You talked about fatigue and hair loss, but yeah, what are some other symptoms that someone could look out for?
The classic ones, so the ones that people are always concerned about are either fertility or the men's sexual health. So that in terms of desire, libido, so desire to have intercourse, that's your libido. If that starts to drop, people are getting concerned that their testosterone is dropping. Could of course be directly related to fertility. But symptoms wise, the ones that I always think about when people come in are, of course, there's the sexual health piece, but the mood symptoms typically are the ones that trigger me most often to run these labs. So low motivation, feeling like you're not yourself, feeling like you don't have that drive to get stuff done is a really common symptom that I'm looking for. But it could tip over into actual clinical depression. So a lot of my clinically depressed patients, we're going to be looking at this. But even so motivation, depression kind of filters along a few different gradients, but a part of the depression piece is typically just low energy and feeling like you're lethargic or you don't have the get up and go. So you might be willing to go work out, but you don't have the zest when you're in the gym, right? And maybe even if you push through that, you don't feel like you respond or recover as quickly after the gym. So we have the sexual health groupings, we have the mental health groupings, the cognitive function. In that bucket, there's also things like poor concentration, decreased attention span, decreased short-term memory. And then in the physical side of things, I'm usually talking about, of course, energy is number one. So fatigue is going to be the number one thing that people complain about. And then recovery from exercise. If that isn't good, I'm going to be asking a little bit more deeper questions. And then not being able to add muscle is a little bit more of a specific one, but it is a concern, especially for my patients that are 25 to 35 and they think they're working really hard and they're just wondering, is is my problem as a hard gainer. That's what it's called. If you're really trying to work hard and gain muscle mass, but you're not able to, or you're finding it more difficult than all of the friends that you're working out with. If you're a hard gainer in that way, those are often people are they're going to be asking about testosterone labs, and rightfully so. That's a very good indication.
Yeah. So would something like caffeine or pre-workout kind of maybe mask some of those
Absolutely.
symptoms?
Yeah, we do a lot of things as men, and I'm going to generalize here a little bit. Men are very good about trying to solve problems, and that's part of our flaw too, is we try to solve problems ourselves, right? So we're usually going to go down the rabbit hole of, okay, I'm feeling fatigued. What can I take to help prevent that? Or what do I need to do to make sure I'm getting through the day, or getting basically making sure I'm hitting my goals from work life, family life, personal life. But at the end of the day, I think a lot of us realize when they are going to lay their pillow down at night that they're more tired than they want to be. They're not where they think they should be. Some of us just chalk that up to aging, the normal aging process, that, they're comparing themselves to maybe when they're a 20-year-old, which I don't, maybe isn't the most appropriate comparison, but it still is important to note these things if they're looping in the back of your mind saying, I'm not actually where I want to be in terms of energy, right?
Yeah.
So that's a classic one. So yeah, caffeine is going to be used 100%. Pre-workout is a fantastic example of it, because people don't realize how much caffeine is in pre-workout, and it works. The problem with that is that you're going to have a little bit of a crash later, or it might interfere with your sleep, which technically directly decreases your testosterone level. So if you interfere with your sleep that night because you had pre-workout at a workout right before 6 p.m. or 7 p.m., chances are that caffeine is going to still be in the system circulating, decreasing your ability to get into that deeper sleep, which is the most important type of sleep when it comes to testosterone. So you actually might be shooting yourself in the foot if you're fatigued because of the low testosterone to begin with.
Yeah. In terms of testosterone levels, then, what's like an optimal level? I guess maybe like a few age ranges, because it does decrease kind of by 1% every year. Is that correct?
Yeah, depending on the statistic you look at, you
Okay.
see anywhere between a 1 to 2% drop every year after the age of 40. Before the age of 40, there is not any good science to say your testosterone should be dropping. Technically, if you took a huge population, you're going to see higher average levels at 20 and 30 than you would at 40, but it's not a guarantee that if you take an individual at age 40, that their level at age 40 would actually have been lower than if you measured that same person at age 20. It's just one of those things that it's a little bit of an error in calculation based on when we calculate these data. But yeah, so 40 and beyond, we're pretty likely to see a stepwise decrease or a slow decrease. And there's so many different reasons for that there is actually still a lot of argument as to whether that is a normal thing that's happening or a biologically normal thing that's happening, because those are two different situations. So for example, if it's normal to slowly put on weight from age 25 to age 60, and then you're pretty stable past then. But during that time, if you're adding adiposity and you're carrying around a little bit of extra fat, chances are your testosterone is going to stepwise decrease with that increase in fat. So just by calculating or factoring in that, it takes away a little bit of the association, right? And that's just one potential confounder in the association. So when I talk about normal, there's two things I'm looking at. Have you ever had this tested before? And how does it compare to that? Right. And then two is you can't just look at the total and then make an assumption on how that's functioning in the body, because total testosterone is like your overall pool of testosterone circulating, and that is an important number, absolutely, but it's really more what's biologically available in terms of what's actually symptomatic. So you can have somebody that has fairly normal for their age total testosterone, but bioavailable testosterone is low or free testosterone is low. And if you don't measure those things, you never know. Right. And those are the ones that actually matter. And honestly, there's arguments as to whether or not you're treating a number or treating a patient. So if you're always just treating a number because somebody comes in and their testosterone, for example, they're 45 years old and their testosterone is 10 nanomoles per liter, that's going to be right on the cusp of whether or not the lab flags you. But at that age, that's low. And then if we run the free testosterone or the bioavailable testosterone, we're looking at ratios. And so technically speaking, a lot of people are out there with kind of borderline low. Maybe they're in the 12 to 15 range, not low enough to get flagged, but they're still running at 3 to 5% of that is free, or maybe 35% of that is bioavailable, or 30% of that is bioavailable. So they're just getting by. Another guy with the same 15 or same 12 to 15 range might have 55% of that bioavailable and have absolutely zero symptoms, and they might actually feel great.
Interesting.
Yeah.
It's kind of, excuse me, like when I think of like a female comparison, getting your thyroid checked, it's like, oh, we just look at TSH. That looks okay. We don't run anything else. But I guess in terms of testosterone, do you also look at estrogen, for example? I know like maybe estrogen dominance could be an issue as well, that imbalance of hormones.
Exactly. Yeah. So most common scenario in which estrogen is going to be playing a role or playing a big factor is actually in our obese patients. So if you're carrying around a little bit of extra abdominal obesity, so any of that tissue is actually still metabolically active. Part of the role of fat is actually to convert testosterone into estrogen. So all of the estrogen in your body was testosterone at some point, and then it's been converted down the stream, down the chain, right? So what I always do when I'm doing labs for androgen profile or for testosterone is I'm looking at total free bioavailable testosterone. At the very least, I'm looking at estradiol, which is the main estrogen. Ideally, I'm also looking at either total estrogens or something called estrone, which is E1. I'm also going to look at a binding protein called sex hormone binding globulin, SHBG. And then ideally, I'm looking just one above stream, which is the LH-FSH. So it's the signaling from the brain down to the testes, as well as one level below testosterone, which is conversion into DHT, which is a specific, more potent form of testosterone that is really active in specific tissues of the body, such as your hair glands or genital tissues even.
Right. Yeah. In terms of, I guess, the why, like other than just a natural progression of age, what are some other reasons that maybe a younger person in their 20s, 30s might experience that drop in testosterone?
Very most common that I'm going to see is overtraining. So I do see a decent population of high level athletes. And so patients that are over 10 to 12 hours of training in a week will usually get gonadal suppression at that point. And so that's going to be very common in our patients that are potentially college level athletes or above, and or people that have prolonged history of training. So you could be a marathon runner. Maybe you're not running at a 10-hour per week, but your average over the past 5 years has been somewhere between 8 and 12 hours. There's a very good chance that you've actually had suppression of that system. And not only just a little bit, the biggest suppression that I've ever seen in the medical literature was due to an exercise related, basically it's a exercise related condition called relative energy deficiency in sport. So it's a combination of working out really hard or your training level is really high and your calorie consumption is really low. So, or it's low relative to your exercise consumption. So you're burning so many more calories every day than you're eating. And over time, your body just will deprioritize function like fertility. There's no need for it because you're under a lot of stress and we're going to try to make sure you stay alive. So it starts to really pick and choose. These are the same people that have immune dysregulation and they get sick all the time, which interrupts their training anyways. It might actually be a good thing. but it's one of those classics. So if you're really training hard and you're a high level athlete, that would be one thing that I'm going to be looking at is your total training load, and then whether or not you're adequately fueling your training. Very common also in our hustle culture is the lack of sleep. So that'll be the second thing that moves the needle the most. So in line, I would say with the exercise training piece, there's also, if you're under fueling, even if you're not exercising a lot. So if you're trying to cut weight, for example, for whatever reason, you will have a decrease in your testosterone during that time. Usually when you bring the calories back on board, your testosterone should bump back up. If you've been cycling yo-yo dieting for a while, that flux is slow. And in some patients, it doesn't really come back up much and it just stays low. And those are patients that often end up being prescribed testosterone replacement therapy quite early on in their life. Is simply because they've kind of gained and lost the same 30, 40 pounds. And they've had fairly wild swings in their energy regulation, right? Which testosterone is a part of that energy regulation picture. But aside from those two, sleep is the next one that is most common. And it's just even a single night of sleep will affect your testosterone levels. So if you get about 5 hours of sleep tonight, tomorrow your testosterone levels drop by about 10%, which is some people enough to put them into a clinically hypogonadic or low testosterone state. And so you want to make sure, if you went and got your testosterone checked, you do want to make sure that blood draw the next morning is after a decent night of sleep, or at least a normal night of sleep for you.
Right.
Yeah. And then of course, chronic sleep deprivation is even worse. It's usually right around 10 to 20% over the long term. And that's going to stay low, right? So you have this low testosterone simply because you're not getting enough total sleep hours, which usually means you're not cycling in enough deep sleep hours. And if you're not getting the deep sleep hours, you're typically not going to get that hormonal pulse, which is the hormone that comes from your brain. It's called luteinizing hormone, LH. That's the one that goes and talks to your testes to tell it to produce more testosterone. The LH is actually a pulsatile. It's like a beep beep. It's like a little big spike, drop off, and that's how it functions. And that the waves of pulses happen way more rapidly and frequently during deep sleep.
Oh, interesting.
Yeah.
I guess when I was, I read somewhere that like lifting heavy weights helps kind of improve, like building that muscle mass helps improve testosterone production. But so when you were talking about the overtraining, is that typically like a high cardio combined with low calorie versus if you were, moderately training, but doing like weightlifting would be better?
Yeah. So the answer to that is yes. Dose matters here. So there is a pretty famous study that looked at Olympic athletes in the 2016, I think it was Rio Olympics, 2016. And they looked across the field, and there was 25% of these male athletes that were diagnosed low. They basically had low enough testosterone that would be considered hypogonadism, and it was across the sport spectrum. So it wasn't just the cardio. Wasn't just the marathon runners. There was track and field athletes, of course. There was actually power athletes in there, literally power. What do you call them? Basically power sport athletes. There's a number of different. There was rowers in there, which are typically very, very strong, large individuals. So I guess the point I'm making is like some of that exercise induced drop in testosterone can be mitigated just by eating. And the type of exercise does matter because the long, steady exercise typically does lead to a more reliable decrease in testosterone. But if you're a normal human being and you're just somewhere between, you're healthy, you're working out for health, you're somewhere between 2 and 6 hours of training. So 6 hours of training might be a lot. You might be lifting weights, might be in the gym for 30 minutes, 4 times a week. You might be going for a couple of runs. You're unlikely to get at that level where you're getting suppression. So you're actually on the opposite side of the spectrum. If you're gaining muscle, just exactly what you were just saying, if you're gaining muscle, and even if you're not gaining muscle, exercise has a short-term boost in testosterone, but it is a short-term. It's a short-term pulse. It doesn't change the overall total testosterone reserve a ton. But with that said, if you are going from over fat or obese and moving into lean or normal weight, you are going to get an increase in testosterone. Absolutely, right? So it depends on your baseline and what you're exercising for. But the general thought is, yes, exercise that involves a large amount of muscle mass, especially strength training work, will, at least in the short term, improve your testosterone. Absolutely.
Oh, okay. So yeah, I guess those are some lifestyle changes to help with that testosterone production. What about diet and kind of a nutrient perspective?
Yeah. So diet is interesting because there's a million articles written on diet and testosterone. And I have a very underwhelming view of it, in the sense that the majority of the actual interventions that even are fairly aggressive changes to people's diet show a 2 to 5% fluctuation either way. Now, the important piece is that a lot of healthy diets overall are associated with a 2 to 5% decrease in your overall testosterone, which is interesting. So yeah, so it's like the way that I approach that is, first of all, 2 to 5% is it may be meaningful in the right person, but in most people, it's not a meaningful change. So I would not be choosing your dietary approach just because of your testosterone level. Like, so for example, the Mediterranean diet, which is kind of universally thought of as the healthiest diet in the world, simply because it's been studied the most. It's been studied the most, and it has positive outcomes across a number of different conditions. And so it's likely that that's helpful for you overall. But the Mediterranean diet has been shown to decrease your testosterone a small amount over the short term. We don't know if that regulates over time. If you're used to the diet over time, potentially your testosterone will come back up that 2 to 5%. It's hard to say because those long-term studies haven't been done, and they probably won't be done, to be honest. But it's one of those underwhelming aspects of the lifestyle that you'd think have a bigger effect, but it really doesn't. The big effect really is what I was alluding to earlier, which is making sure you're getting enough calories in. Okay, so if you're low calorie, and technically speaking, if you're low on protein, you would lose that stimulus as well. But again, it's hard to be low protein unless you're low calorie, technically speaking. But again, it's relative to your workout, relative to your exercise level.
Right.
Does that make sense?
Yeah.
Yeah.
Oh, that's interesting. So yeah, because I always thought it was, you want to maybe focus on nutrients like zinc and selenium. But
so let's go through those, because those are really common supplements, right? So zinc, selenium, vitamin D, different antioxidants have been all tested against for testosterone boosting effects. And there is an effect for vitamin D in patients that are hypogonadal. So if you're starting from a low testosterone, total testosterone below 10, below 8, something around there, you might get an effect from vitamin D. And those studies are usually somewhere between 5,000 and 10,000 IUs a day. So it's a fairly high dose. And usually the effect will moderate after they correct their deficiency. Zinc, time and time again, it shows no effect at all. Now that's different than saying, that's the studies that are actually adding in zinc and comparing it to placebo and showing that there's no effect overall. That's different than saying, don't worry about your zinc intake through food, which I do. That's the approach that I take. Is absolutely, zinc seems to be important in testosterone production if you look at it mechanically. And so I would not be deficient. I would make sure that I'm eating enough zinc rich sources of food and or supplementing wisely under the care of your primary care physician or medical provider, because zinc is a tricky nutrient too. You don't want too much of it. It'll start to deplete copper and things like that. So typically, if you're taking a supplement with the only intention of increasing testosterone, overall the effect is really modest, and it's very unlikely to affect you if you already have normal testosterone levels, or somewhere which would be considered eugonadal, which is somewhere between 12 and 30. which is a huge range. There are a couple of herbs that seem to be effective in really specific populations. And again, that's not one that I would rush out to the store and get, because it's not going to make a huge difference if you're not doing any of the other stuff.
Right.
In fact, you will probably not notice a difference if you only added a supplement that had some herbs like Tonkat Ali, or basically any of the herbs like ashwagandha, which has been tested for in low testosterone. If that was the only thing you did, and I would not put money on that's going to change your overall testosterone level over a 6-week course or a 12-week course. So whenever I'm prescribing those things, it's in conjunction with something else. It's an overall approach.
Oh, interesting. That is so interesting.
Yeah.
That seems so backwards, but yeah,
With
I
the
guess
healthy diet, you mean?
Yeah.
Yeah.
It's like just eat whatever you want.
Yeah. Well,
Eat
it's nuance,
McDonald's every day,
right? It's
yeah.
nuance, right? So that's why a healthy diet is in reference to, it's an overall pattern of living which is consistent for specific outcomes. But if you think about testosterone, it's one of those weird things where there's a biological need for reproduction up until, evolutionarily speaking, maybe 30. So there might be some aspects to our biology which thrive and push those pathways up into a certain point, and then they basically atrophy over time. And the goal to just basically try to get yourself back to those levels. And if that's the goal, like, why? What are you actually going to achieve by doing that?
Yeah.
Right. Which actually is a nice, like, kind of microcosm of the entire field, because right now there is a lot of research going on to specific populations and using testosterone replacement therapy, for example, because it's very common to test people above the age of 40 and they're going to have a low testosterone or suboptimal testosterone. It's very common. So now you have this dilemma. If it's common, some people are symptomatic, but some people are not. How do we track treatment progress? Are we just treating the number? So if you're just treating the number, okay, let's get everybody up to a physiologically normal range, somewhere on the, whatever a normal healthy 25-year-old or a normal healthy 30-year-old, nothing crazy, but high enough that you're probably going to correct any deficiency, and then you track them over time and you see different outcomes. So time and time again, that is effective for what most people are looking for, which is correcting certain sexual health dysfunction. Certain aspects of fatigue and anemia have been corrected very, very clearly in clinical trials using testosterone replacement therapy. Sarcopenia or osteoporosis. Sarcopenia is the loss of muscle mass. Osteoporosis is the loss of bone mass. Testosterone is really important for both of those things. And so there's actually trials putting that to the test. So if you're somebody that has had low testosterone for a significant amount of time, you're at a higher risk of fragility fractures, osteoporosis, and loss of muscle mass. So there's been studies putting those people on testosterone replacement therapy, bringing them up to a replacement dose where their overall levels look pretty good for 6 months at a time. And then they see, does that improve their bone mineral density? Yes. How much? Yes, enough that it's clinically significant. We seem to see an improvement in muscle mass as well. Very similar effect. So like there might be a role here where, using these biological mechanisms that were really thriving for us earlier in life and kind of adapting them later in life might be very useful for certain things, but it's not going to be really useful for everything. It's not going to cure a lot of our problems, because testosterone is not the root of a lot of our problems.
Right.
Right. So if I'm treating somebody and they already have, if they have diabetes and cardiovascular disease and maybe dyslipidemia or something like that, those, for example, that diabetes, if it's not well controlled, can decrease testosterone.
Right. Okay.
If they're on a statin, sometimes that can actually decrease testosterone a really small amount, but it's still enough. So you can manipulate their diet in other ways, correct or control the diabetes, correct or control the hyperlipidemia with lifestyle. Their testosterone will naturally come up a bit, simply because you took away those obstacles. You took away the reason why they were low in the first place.
Right. Yeah. So it kind of has an indirect kind of
Very
effect.
much so.
Yeah. I guess in terms of stress, as you mentioned, it's kind of a big factor as well.
Yeah.
What are some of your kind of recommendations in terms of managing stress for your male patients?
Yeah, stress is such a big one.
I know.
Stress is such a big topic. I'm a really big fan of doing a little bit of a lifestyle audit on your stress. So very few of my patients recognize when stress is affecting their life or affecting
Mhm.
their health. It's not until you ask them a couple of pointed questions and get them thinking about how it affects them that they really understand that it's probably holding them back in some way. So I'm a fan of stress and dosing your stress appropriately. But when chronic stress or ignored chronic stress is clearly an obstacle to cure, I'm going to bring it up with my patients,
Mhm.
right? And so this is very individual because some people will be stressed chronically and interpret that as a bad stress from the same stimulus that other people get energized and motivated for. A
Mhm.
classic one is like public speaking or performing or being in front of a crowd. If you have any performing friends, like they get energized, they live for that moment. They actually, yeah, of course, they get the same surge in cortisol and adrenaline, but they do not interpret that. They could be on the stage every single night and they're not going to be stressed by that signal, right? The opposite would take place in somebody who might have a presentation at work and they're worried about it for like weeks at a time,
Mhm.
and it's slowly ticking away at the back of their brain, talking about, hey, like you got to prepare for this, you got to over prepare for this, you got to make sure you have all your ducks in a row before you do this because you don't want to look like a fool. You don't, remember last time when you said this one thing and nobody laughed, and so
Yeah.
I think that stress is a big piece. So to answer your question more directly, the tools I give in office are really simple, and that's stress is, typically we need to engage the nervous system in some way that you can give back some locus of control. So breathing exercises are going to be a big piece of the pie. For me, I'm always going to teach my patients some form of a breathing exercise that they can use in the short term, as well as something that they can use over the long term, which usually, some people would call this like a mindfulness based activity. Sorry, this light is like flickering on and off.
No worries.
2 seconds here. Just going to turn it off. Okay. Now it's a little bit dark, but
That's all right. Less stressful.
yeah, less stress. Yeah, mood lighting. Yeah. So in office stress-based therapies that I'm going to teach my patients are often going to be some sort of a breathing exercise. There are some really well studied evidence-based breathing exercises, like paced breathing, box breathing, and the like, different forms of diaphragmatic breathing that can give patients a little bit of a locus of control over their stress.
Mhm.
I'm also a very big fan of resiliency training, which is it's kind of one of the reasons why exercise tends to be good in terms of patients being able to handle a dose of stress and their body actually gets stronger from it. They get more
Mhm.
resilient and more robust. I'm not a fan of just avoiding everything in our life. There's going to be tough times and tough seasons. And so knowing that and building your resiliency ahead of time is a really big key. And I think that some people, this is actually really in vogue right now, which is using things like cold immersion therapy or even saunas on the opposite side of the spectrum. So fluctuation of temperature and exercise are two of the most common types of resiliency training that I'm going to be prescribing. And so it's really what the idea behind it is you blast your nervous system with a stress, an acute stress, and then you let it deal with that and go the opposite way. So it actually becomes a
Mhm.
really calming type of a therapy. If you can imagine, like an example would be doing a cold shower. So if you do a cold shower at the end of your shower, you get a little blast of really aggressive change in stimulus, right? And some people, if they're not used to it, they're going to be hyperventilating or they're going to be gasping for breath, gasping for
Mhm.
air. Your nervous system will respond to that cold by really aggressively trying to heat up, right? So you get out of the shower, you'll notice that the air around the shower is actually not cold. you feel a little bit more resilient to the fluctuation in temperature compared to just yesterday when you got out of a hot shower and now the air feels cold or cool and you feel like you need to wrap yourself up in the towel. So there's a very, very small example of that. But as you do resiliency training like cold immersion or cold showers, even if you wanted to do something simple like that, that cold it gets easier. You have to now have a higher stimulus for you to get the same reaction. So unlikely you're going to be hyperventilating a week from now if you're getting used to this, right? Unlikely that you're going to even breathe much different. You're going to probably be able to breathe through that. You're going to be able to take more of it on your face, your back, your neck, or some of those sensitive spots, right? And then maybe jumping in the Bow River gives you the hyperventilation. Like that's the next step, right?
Yeah.
And so you can always move that needle in a very safe and controlled manner, which takes very little time. And it trains your nervous system to go into stress and then all the way back into I'm safe, I'm fine, I'm good, I'm rest and digest side of the equation. So those are ones that I like to talk about simply because it's a free tool or almost free tool that most people can use and most people get the idea behind it and they can get on board with some form of it. Even when exercise seems like a little bit of a stretch because there's a time component to that. A cold shower seems like, well, I already jump in the shower anyways every day, so it's an easy thing to ask somebody to do.
Yeah.
And then at our clinic, as you know, we do a lot of we do brain mapping, quantitative EEGs, and neurofeedback, and that's a very big piece of my pie. Is kind of an objective view on the entire nervous system and the connectivity between the different parts and how you as a whole is functioning and compensating from your stress currently, because that enlightens. I think that when I go over a brain map with patients who I know that they're stressed, but they're not really aware that they're stressed, you can clearly show them on the brain map what parts of the stress pattern or parts of the stress infrastructure are lighting up like a Christmas tree, right? And for example, you can actually on a brain map show parts of the infrastructure of stress and anxiety that is related to the external manifestations of stress or anxiety, like what people would assume is that person's stressed, that person's anxious, you can see that part, or you can see a completely different part, which is all internal. So it's all under the weather. It's all underneath the ocean, right? Where people on the outside, they look totally fine. They're able to kind of get all their ducks in a row. They're able to, meet their obligations and their responsibilities in all their different areas of the world, but they're inching closer and closer and closer to burnout without even realizing it. And it's a nice way of us showing that to a patient who needs to see it.
Yeah, absolutely. And I think that's important that you mentioned that. Like, I know a lot of women are like that too, but I feel like men especially, struggle more with really saying how they're actually feeling and what's going on, in terms of depression, things like that. That can be very tricky to kind of get that information out of them. So
and to be honest, that's where having somebody like myself who, I work with men a lot, so this is a big piece of I'm totally comfortable having these conversations. Most patients are totally comfortable having these conversations, and they can open up in a way that they wouldn't necessarily want to with their spouse.
Right.
As bad as that is, I mean, it's very, very important that they talk about it regardless of who it's with, and seeking some help, because that sometimes is the hardest part is asking for help. And so if somebody's already in my office, I know they've made that first step, and I'm willing to kind of hold that space for them if they need it. And if they need, additional referrals. So if you have major depressive disorders, typically you're going to be a team game. And most of those patients aren't reluctant to ask for help, but I'm one piece of the pie in that case.
Yeah, I think a lot more men and maybe women just struggle from depression in general, but I know with women and men, sometimes the symptoms can present differently. So for the male group tonight, what are some of those symptoms? Because maybe they don't even realize that would be a symptom of depression. So what are some of those symptoms in men?
a few things that I always key on. One is a lack of motivation. And then the other one is the lack of pleasure in previously pleasurable activities. So, and then the third one, I'm just going to throw this one in, is irritability and anger. So that you wouldn't necessarily associate that with depression, but when you're really frustrated about your internal and external environment and you're depressed about it, you often will react with irritability. You're just, everything pisses you off. And you're like, why does everything piss me off? I was previously optimistic and now I'm kind of like a cynical old man, like depending on it doesn't matter what your age is. So that's one of those. And then I think that the motivation, the lack of motivation, the feeling like you're just kind of coasting through life and lack of purpose, which goes along with that. Often that's one of the places that we'll start a conversation about, is kind of the purpose piece of things. But those are some of the ones that people wouldn't necessarily think about. Of course, fatigue, oversleeping and undersleeping can be associated with depression. So I do ask those questions if I think that somebody is oversleeping.
Mm-hmm.
Yeah, and then generally speaking, if they aren't finding anything that's pleasurable in their life, so if they previously enjoyed specific hobbies and they're no longer doing those, they're withdrawing, they're socially isolating, that's going to be a big red flag. Yeah, that's kind of where I would go.
Yeah. Even with depression, spinny chair. If they're on medication and they're not getting better, that might be an indication to get your testosterone checked, right?
Absolutely, yeah. They do go hand in hand, and there is actually trials with, again, testosterone replacement therapy in major depressive disorder that show clinically significant, not just statistically significant, but clinically significant improvement in symptoms and decrease in depressive symptoms. That's really important. Now that I should mention one more thing, is one of the most common symptoms of depression is actually anxiety. So people kind of categorize these as separate, but they very commonly, anxiety will be a manifestation of depression. So if you're feeling a little bit anxious, actually this plays a role in the men's health. This is actually a nice segue, because some people might be coming in for performance anxiety in terms of erectile dysfunction. Right. So a lot of people will come in thinking that erectile dysfunction is simply a result of their low testosterone, or they're hoping it is, right? They can just get it cleared by correcting that. But very commonly, actually, first-line therapy for erectile dysfunction is cognitive behavioral therapy. It's treatment that's really designed for anxiety and depression that's really, really effective for erectile dysfunction. And really specifically the type of erectile dysfunction, which is a performance-based. So it's like sometimes you get you're fully able to attain and maintain an erection. Other times you can just attain it and then it just peters out. Other times you can do neither. You're having a difficulty, attaining an erection. That piece of the pie is very closely related to anxiety. So which is very closely related to depression. Right. But then just to answer your question, of course, yeah, I would absolutely be testing testosterone in patients that are clinically depressed and refractory to treatment, which means that their current treatments are still not doing enough.
Yeah. And in terms of the testosterone, like taking that as a bioidentical hormone per se, is that something like in combination with lifestyle changes that works kind of better together, or is it one or the other?
They're better together for sure. So
yeah,
there's a lot of forms of testosterone replacement. There's a lot of pharmaceuticals that aren't direct testosterone replacement that work quite well as well. Specific fertility drugs that have been studied time and time again that work equally as well, including like Clomid. Even HCG has been used for that. There's specific peptides that have been studied as well. I won't dig into that just because it's a little bit of a gray area. But lifestyle, the piece that I'm always working on with patients is why they're there in the first place. I in the province of Alberta, I cannot prescribe testosterone. So I was trained in Arizona. That was a scope of practice. That was something that I did quite frequently when I was down in Arizona, but in Alberta, I'm not allowed to do that. So it's not that I'm not referring for it.
Mhm.
It's that I'm finding you can go a long way with the lifestyle advice and the lifestyle changes and then identifying the underlying cause of the low testosterone. And then in some cases, you still need the testosterone replacement therapy, but it's a lot fewer than I thought it was. I used to, it's funny because when you have a tool like testosterone replacement therapy and it works really well, and
Mhm.
you're in a place where you can prescribe it easily, like I don't blame physicians for prescribing it because it works so well and patients feel great and they think you're the best doctor ever.
Yeah.
Right. So it's really a rewarding type of it's one of those few medications, honestly, that you get like a really quick feedback with patients where they're
Mhm.
actually happy with you.
Yeah.
And a lot of, so there's an interesting dynamic there. But since I've been out of that, I've realized you can get a long way with just with the lifestyle medicine and optimizing, especially things like sleep and exercise and caloric consumption and things like training load and things like that. But testosterone replacement therapy is still absolutely required sometimes. It just is. Some people are not. You can test this too. You can see how responsive somebody's testes are to various different stimuli. So if your
Mm.
testes just are not very responsive and they're not actually producing a lot of testosterone, you're unlikely to respond to most lifestyle therapies.
Mm.
Because it's really it's a failure of the testosterone. Sorry, it's a failure of the testes producing cells, the Leydig cells in the testes. So you're unlikely to grow new Leydig cells at any time soon. So you're probably going to need a replacement. And if you're replacing to a physiologically normal level in a dosing manner and basically, yeah, dosing manner that you find comfortable over the long term, and the physician is helping you track the important things like your red blood cell count and your kidney function, your liver function over time, there's very few risks. You can do it very safely,
Mm.
even over the long term. So things like you can mitigate basically all of the risk in terms of cardiovascular risk and cancer risk and all that stuff too, because you're in a physiologically normal range. You're not, you don't compare to the people that are hyper dosing testosterone for use in terms of like anabolic steroid use for
Right.
bodybuilders or professional football players or the like.
Yeah. Awesome. Um, and in terms of just going back to diet for a second, are there specific things that people should avoid? Like, is alcohol a big factor? Smoking,
Oh
pretty
yeah, good ones.
common
Those are
sense
good.
wise, but yeah.
Yeah, those are good ones. Yeah, smoking and alcohol are both actually very closely linked to hypogonadism, alcohol more so. Dose makes the poison, and specific types of spirits and beers seem to have more of an effect than others.
Hmm.
So, interestingly, people are always really worried. Like, I can't tell you how many times I've talked about soy in my clinic and how people are worried about that that's going to affect your
Right.
testosterone.
Yeah.
It does not affect your testosterone at all, like 0%.
Hmm.
You'd have to be dosing like 16 to 20 cups of soy milk a day. Like basically all of your calories would have to come to soy milk and you're still going to have a really mild effect. It doesn't really affect testosterone anyways. It's more of it affects the estrogen receptors. And even that is more complicated. It has to do with which receptors it's activating. It actually has more of a selective estrogen receptor modulating effect, meaning that it just in some areas of the tissue it kind of estrogenic, in other areas it's anti-estrogenic. So in the places that you want it to be estrogenic, like the blood vessels and the bones to prevent cardiovascular disease and to prevent osteoporosis, it's helping. And in places like uterine tissue for women or breast tissue in both men and women, it's non-stimulatory. It actually is the opposite of that.
Mm.
So it does not give you man boobs in any way. So anyways, soy is just one of those things that I think I just tell people, don't worry about it. Like if you have
Yeah.
soy, great. There's no problems with it, especially for testosterone, it has no effect. But if you think about the phytoestrogen class, there's one phytoestrogen that's like, I think it's 8 times more potent than soy. So, theoretically has a way of affecting the endocrine system. And that's hops in beer. And of
Oh,
course, and a lot of
interesting.
people will have the hoppiest beer around, like a triple IPA, and they're like, "Oh,
Yeah.
this is the
Yeah.
best beer ever," and they're having 17 of them. And so you can get up to a physiologically relevant dose of a phytoestrogen through the form of hops. Right. And then of course the alcohol itself has an effect on the testosterone directly. So there's probably a relationship there, which, so I guess dose makes the poison there, of course, as well as the type of spirit that you're having, the type of beer that you're having. I would opt away from the hoppy beers. If you can, give it a try, see if that helps you.
Oh, it's interesting.
Yeah.
Break a lot of hearts.
I know, right? Yeah. It's like IPAs are kind of going away now. They used to be the only beer you could ever get when you go out.
Yeah.
But it's one of those things. There's not a lot of, like I said, there's quite a few phytoestrogens in our environment, and then xenoestrogens are like the plastics, right?
Right.
And there is actually good data on various types of xenoestrogens, from phthalates to BPA, which clearly do show a decrease in testosterone. So I think that at a population level, that's actually a very strong reason why tends to be getting more of a problem and not less of a problem. I think a large part of it, of course, is just that we're gaining weight as a society too, which is not helpful. But the xenoestrogens probably are one of those things that you can manipulate in your environment that will probably help as well.
Yeah.
More so than the phytoestrogens, more so than the dietary stuff. The phytoestrogens as a class are not strong enough to really do anything.
Right. Awesome. Let's get to some questions. So, is there any relationship between micronutrient levels and testosterone levels?
Yes. So if you're low on zinc, actually, we talked about a little bit on this. Any of the divalent cations, so iron, zinc, selenium, magnesium, calcium, have a relationship there. The zinc is the one that's been best studied. So yeah, if you're technically deficient in these, which is more rare than you'd expect, that can decrease your testosterone. And it's nice when that's the case. Like, I wish this was the case more often, because it'd be the easiest fix ever to just change somebody's, give them a micronutrient, or basically give them a zinc supplement. Or most of the testosterone formulas you get over the counter right now have zinc in it, and they have selenium in it. I would always say, look to make sure you're not also taking zinc in other forms. So if you're taking zinc in your multi, you're taking it on its own for immunity, and you're putting it in your testosterone formula, can pretty much guarantee you're getting too much zinc. And it'll do the exact opposite of what you're expecting it to do. So high zinc will decrease your immune response. High zinc will decrease your the health of your skin. High zinc will decrease your spermatogenesis production, and your testosterone production. So
yeah. Would that be then more like focusing on diet, like seafood, for example? You're getting more of that zinc copper balance in diet.
Huge. Yeah. So if you can get it through dietary sources, I think you're probably either on a very restricted diet or you're a little bit lazy. There's some things in our soil that seem to be depleting. Things like magnesium is getting a little bit harder to get natural. Get 400 milligrams a day in that. That's still possible. It's just you have to be a little bit more cognizant. I'd say in general, I don't want to be paternalistic there, but you do want to make sure that whatever diet you're putting together, you're actually putting in some work on the front end and figuring out where the gaps are in your current diet and how you can fill them with specific food-based changes. And if you're really honest with yourself, you might find some of those things are just, you're never going to get them through food because you just don't like those foods. Right. So zinc, for example, zinc, magnesium, a lot of these nutrients that are really important for testosterone levels, actually, you could, an example would be you eat a half cup of pumpkin seeds. Like that's 100% of your daily value in all of those things. So, but some people hate pumpkin seeds, and what's the chances you're going to get a full half cup of pumpkin seeds in a day, right? It's like, so it's one of those things that you could do some of this with just food, but you have to actually put together your diet with some intention and not just hope it happens. Yeah. Actually, I think this is something that I've been talking about a lot with my patients, which is the more health conscious my patients are, the more likely there's gaps in their dietary pattern. And simply because they're avoiding processed foods, which have been fortified to basically make sure on a population level, the people that are not trying are still getting enough, right? So if you're not trying at all, you're getting a whole bunch of these fortified foods. Yeah, of course, there's problems with those processed foods, but at least they're not deficient in these really common nutrients. Right. Whereas you take somebody that's really specific about their diet and they're very conscious about it, but they're like almost on the side of like too healthy and too restrictive. They're the ones that have to do the most work up front to make sure that they're not low in iodine. Like who's low in iodine? Well, everybody that's not eating dairy and seafood, which is a lot of people.
Yeah.
So it's just a really random example.
Yeah, no, that makes sense though. I think you're absolutely right on that. So what are some environmental factors that can contribute to low testosterone aside from weight and age?
Yeah, so those xenoestrogens I was telling you about. So BPA in our environment right now, of course, we used to think about it just from our plastic bottles. BPA is going to be found in receipts though as well with BPA lining. So that's one of those ones that you would want to minimize your exposure to hot liquids, especially, or hot foods being heated up in any sort of plastic. That'd be the easiest first thing you can do is you store as much of your food in glass as you can. And then when you do heat something up, it's never in plastic because you're pretty much guaranteed, if it's not BPA or another type of phthalate, well, it's a chemically comparable compound, which is very similar to have the exact same physiological effect. We just haven't studied it enough, right? So BPA-free water bottles, for example, have been, they're filled with BPS. We're pretty sure it has the exact same effect on the hormonal system. We just haven't had as much study. Or BPX, same thing. So environmental factors like that. I think stress is a big piece. Heat. So technically speaking, if this is a little bit more related to, it's a niche thing, but it's a little bit more related to fertility, but it does have an effect on testosterone, is if your testes are always too warm, your testes in general will not be functioning very well. And that includes your testosterone production. So if you're always wearing really tight fitting underwear, it's really warm all the time, you're taking frequent saunas or hot tubs, that can be an issue. So it's certainly one of those things that if you're taking saunas, you might want to bring in a cold water bottle or something like that with you. If basically you might want to wear some looser fitting underwear and that kind of stuff, especially if you're somebody that's worried about your low testosterone because of fertility. 100% I would be making change that way. And then stress is the big piece, because stress from male and female on the adrenal side of things, as your testes do less and less work, or in women when they're not doing any of the work, your adrenals are really making up the slack. So they'll be producing testosterone. More and more of the testosterone will be coming from your adrenals. And of course, your adrenals never fatigue and they never stop being able to produce the hormones, but you are going to be having an effect from like a stress level effect on the ability of the adrenals to function normally and convert tissue normally, right? So you're basically metabolically putting more stress on a tissue that, just like any other cell, has to cycle, certain cells, if they're not functioning well, still have to go through apoptosis and die and all that good stuff.
Yeah.
So without going into a ton of detail, I think we talked about this enough in that one.
Yeah. Do thyroid hormone medications have any impact on testosterone?
Yes, mostly conversion of testosterone into its active tissue at the level of the receptor. So your thyroid hormone, if you're not actively seeking treatment for low thyroid, the low thyroid will decrease the conversion at the level of the tissue. So you're actually going to get a little bit less DHT production, a little bit of the less stimulation of the androgen receptor as well. So you might look like you have low T even though you don't. But the medications themselves shouldn't have much of an effect. Like if that's the question on like Synthroid, for example, or Cytomel, or the ones we use a lot of, which is the porcine gland versions, the glandular thyroid hormones, they don't They don't have an effect with the exception of the absorption. You would want to take them away. If you're supplementing with both of these things, you would want to take them separately, if that's the question.
I think we answered kind of the correlations between weight training and HGH as they pertain to testosterone. Yeah, we talked about that.
Oh, okay. What sort of correlations are there between weight training and HGH as they pertain to testosterone? I think we talked quite a bit about that. Human growth hormone, that's HGH. It's different than testosterone. It's very important. It's another anabolic stimulus. It's also mostly produced at night. The testosterone is later in the night. Growth hormone is earlier in the night. Growth hormone has more of an effect at a cellular level as an anabolic stimulus, and it'll drive a lot of different repair pathways that are outside the muscle. So testosterone will have a little bit, it's hard to say. They're both so intricately related, and they both will increase slightly with a bout of weight training. So if that's the question, is in regards to weight training, you will get a slight boost in both of these anabolic hormones after a bout of training, which is a good thing because it's a response to the stress of the exercise. And now your body is getting a signaling repair, which will also go along with things like insulin and stuff like that. So insulin and IGF-1 and human growth hormone and testosterone and anything that stimulates the androgen receptor, so DHT, testosterone as well, are going to be basically responding to the stress by leading to increased anabolic signals and repair of the structure afterwards.
Yeah. Yeah, there's just a few more like specific questions. I don't know.
Yeah.
Kind of over time, but totally up to you if
So let me just talk a little bit about intricacies of testosterone replacement therapy. I think they're this is a discussion to make with whoever's prescribing it for you. So whoever's prescribing it for you needs to discuss with you the benefits and the downsides to gels, patches, pellets, injectables, and the like. Because if you go online, everyone's going to have their own opinion, and the opinion is irrelevant to your specific scenario. If you are worried at all about your red blood cells going up too high, injectable testosterones are going to be worse for you. That might be exactly why you're going on testosterone. You need to improve your red blood cell count. You need to improve your hematocrit. So you want to do an injectable. It really comes down to the individual and why you're doing it. The benefit of dosing, like if you're trying to mimic physiology, the injectables tend to be the least physiological because they get a huge bolus. We'll go super physiological, which means you're going to go above range for the beginning part of the week. Let's say you're doing it once every 2 weeks or once every week. You're going to go up too high, and then you're going to start to fall back into range. And then sometimes they'll retest you in this way, and they'll try to make sure that you never get too low before you get your next dose. Other people will allow you to get low, and then because they know they're going to push you up really high. So the benefit of the injectable, of the ease of use once every 2 weeks or once every week, and it being very good at correcting some of the red blood cell parameters is a good thing. But it's a bad thing if you are worried about symptoms that go along with the highs and the lows of testosterone, right? So you might need to talk to your doctor about it. There's different ways that you can do an injectable dosing schedule, inject more often, lower dose, all this good stuff, to make those highs and lows a lot less noticeable or not noticeable at all. But then you have things like creams. Creams are going to be in and out of your system relatively quick. You can dose them really well, but you might rub them off on a partner. You might have inability to put them on a specific part of your body for over and over and over again without it getting too thin or irritated or red or rash. So there's pros and cons to all of these things. The pellets are ones that are really rare here in Canada, but very common in the States, simply because people know the dose that they really enjoy or they really like, and then they ended up going on a pellet, which will just dissolve slowly under your skin and only need to go in, I think, every 3 to 6 months. So it's really easy for a patient. The problem with pellet is you can't change the dose once it's in. So if it's too high, if it's too low, you're screwed. right? If it's too low, I guess you could add some creams or something, but
Mhm.
yeah, so we won't go. I mean, I would say talk to your doctor about that one specifically. Same thing with the Klinefelter syndrome. I'm actually not, I'm not familiar enough with that specific syndrome to really give you an idea of anything other than what your primary care has said there. But hormone replacement therapy, I wouldn't worry. So if your concern is, you know, I would talk to your doctor about specifically your concerns with testosterone replacement therapy. And if you want a second opinion on those things and just go over all of your options in detail, I'd be happy to sit down with you and go through them, because I understand the testosterone replacement well, even if I don't understand the Klinefelters as well. But it is something that's it's really important that any therapy is mutually agreed upon. It's in true informed consent, which means that you understand as the patient what you're getting into, right? You have to know the pros and the cons, why your doctor thinks one thing is better than another, and it's not just his preference or her preference, right? It's really your choice, it's your body. And so if you're really worried about these things, don't go on it until you're ready to make the decision. Don't feel pressured. There's no pressure. Yeah. The last one there, are the results on a sliding scale for testosterone levels relevant to height and weight? No, they're not relevant to height and weight because it's per unit of blood volume. So the amount that we're looking at in the blood, or that we're looking at, is relative to a deciliter of blood. If you're looking at nanograms per deciliter, for example, or per liter of blood, if you're looking at nanomoles per liter. So if you're a bigger person, you're going to have more blood, but relatively speaking, per milliliter of blood or deciliter of blood, you should have an equivalent amount of testosterone. So it should even the playing field a little bit there. Yeah.
Perfect.
Okay, thank you, everybody.
Yeah, thank you. That was awesome. I definitely learned a lot. I'm still a little shocked by the diet piece, but
The diet piece, yeah. What I would reiterate there, though, it's just that it's not a big effect. It's
yeah,
like,
yeah.
so if you look at I can send you the trials too on that. It's not the ones on Mediterranean diet. They're very small. Like if you're looking at clinically significant changes, it's not clinically significant.
Right.
But researchers are built to design studies that show statistical significance, right?
Yeah.
So yeah. And one thing I will say is I did not mention at all the prescription drugs. That last question, I just saw that. Prescription drugs, a very big effect on testosterone. We're always going to ask you about your prescription drugs when we're screening for this. Stimulants, you know, that's another one. One of the more common than you'd expect, I would say, discussions that we have in the office. The prescriptions are trickier because there's always a reason for the prescription, and if we want to manipulate it, we have to have everybody on board. So whoever is prescribing that drug has to make the decision there, or help you make the decision. But it does have an effect. Do a quick Google and you'll find some specific medications, and if you're on one of those medications, you might want to ask your doctor about it. Just say, is there an alternative? A really common one, I'll just throw this in there, is like Tegamet, which is a cimetidine, which is a H2 blocker, or PPI, or not a PPI, but a acid reducer. So for people that have heartburn, it's really common. It does decrease testosterone. One of those things that you never think about until you Google it. So I encourage you to Google these things.
Yeah, absolutely.
Yeah.
Dr. Google.
Yeah.
Awesome. Well, thank you so much, everyone. Thank you, Dr. Nelson, for enlightening us all about testosterone.
Yeah.
But yeah, I will send this recording out to everyone as well, so you can rewatch it. As well, I will provide information if you'd like to work with you as well. I will have that information in the emails in the next few days. So again, thank you so much, everyone, and have a great night.
Thank you very much.